Great surgery can't rescue a bad plan. Most failures start in planning. Today, we plan backwards from the final restoration to biology to numbers and then surgery. Simple, predictable, repeatable. What you'll get is a step-by-step workflow, how to set targets, how to read constraints, how to pick sequence based on biology and skill, and there are some numeric rules to depth, spacing, and tissue that we're going to look at. So we start with the result. Before scans, before implants, ask one question. What must the final restoration be? So we have to take into account aesthetics, tooth position, gingival zeniths, smile line, and lip dynamics, function, occlusal scheme, load path, phonetics, hygiene access, patient goals, time, invasiveness, budget, maintenance tolerance, and the end is clear. Every decision gets easier. Let's have a look at some constraints and biology. Planning is prediction under constraints. They set inflammation and oxidative stress. They decide how much surgery the tissue can tolerate. Let's start with some medical constraints. Diabetes, obesity, smoking, chronic stress. These push reactive oxygen species up, so more oxidation. Antioxidant reserve goes down, and the list goes on. Steroids, chemotherapy, immunosuppressants, antiresorptives. Angiogenesis slows, fibroblasts work slower, and the list goes on. Vitamin D deficiency, poor nutrition, dehydration, redox balance drops, and response from us should be shorter procedures, minimal trauma, cool sharp drilling, excellent hemostasis, longer healing windows, and stricter hygiene. Let's have a look at some anatomic constraints now. Thin buccal plate, limited medullary space, poor vascularity, higher ischemic risk, the sinus and nerve proximity to the area that we're working in. These end up in fewer flap options. More retraction needed means that perfusion falls. Thin soft tissue biotype means fewer capillaries, and this means greater risk for tissue dehiscence and collapse after closure. What should be our response? We have to preserve our blood supply with smaller tension-free flaps. We have to avoid overthinning cortices. We have to stage it when vascular demand is high. Let's have a look at some dental constraints. Parafunction or unstable occlusion lead to chronic microtrauma, and that means oxidative load stays high. Biofilm that is left behind means residual periodontal infection. This means that we have baseline infection even before our incision. If we have low keratinized tissue, that's another issue to take into account. Poor access to hygiene means that inflammation will persist more. What should be our response? We have to stabilize the occlusion. We have to debride and control biofilm preoperatively. We have to ensure at least 2 millimeters of keratinized tissue or plan soft tissue grafts. What is a key principle? Match surgical load to biologic capacity. Redox management is part of planning, not an afterthought. So let's build the blueprint. Start by creating a diagnostic wax app or a digital tooth setup. Align your STL files with your CBCT scan, trace the screw axis trajectory, define the emergence profile, and this will show you where the bone and soft tissue must exist. If anatomy is missing, this will tell you that you need to build the tissues and when to build it. Reverse engineer the plan. This is not yes or no, it's a spectrum. Balance three things: the results you and your patient want, the biology you have, the skills you have, and the time you have in your hands to apply all this. Lock the target, fix tooth position, fix emergence profile, draw the axis line through bone, test reality against target. Can you keep a buccal plate of at least 2 millimeters? Is the distance of implant to the adjacent tooth at least 1.5 millimeters? Between implants, do we have at least 3 millimeters? Is vertical soft tissue plus submergence about 4 millimeters from crest to gingival zenith? What is the biologic capacity? What is the tissue thickness? What's going on with vascularity? Do we have any systemic risks that lead to more oxidation? Choose your sequence by biology and skill. Option 1 would be immediate placement of an implant with simultaneous contour graft. Use this when primary stability is achievable, the defect is contained or semi-contained, and you can stabilize the graft and control the flap. Option 2, soft tissue first. If biotype is less than 2 mm in thickness, or we have a high smile that threatens exposure, we have to build perfusion and thickness by some soft tissue work and then place. Option 3 would be simultaneous GBR and placement, if you can predict space maintenance and stabilization, and then if defect allows it. Option 4 would be a staged GBR and then placement. This is what we do for large defects. Also, we do the same if we have poor tissue, low vascularity, or high systemic oxidative stress. Option 5 would be delayed loading, if risks are high or you need a short operation time. So, match plan to skill and system. Your experience matters, your instruments matter, your assistant and your time matter. Predictability beats ambition. Staging is control, not failure. Quantify and execute. Turn logic into numbers. Numbers remove guesswork. Soft tissue first. If vertical thickness is less than 4 mm, you have to deepen the platform or plan for connective tissue graft. Aim for about 4 mm. From crest to gingival zenith. Buccal plate next. If post-placement thickness is under 1.5 to 2 mm at least, you have to augment to reach the 2 mm or more. The depth rule is we have to set the platform depth by the 4 mm target, not by the bone crest. Redox, guardrails during surgery, sharp drills, abundant irrigation, short flap time, tension-free closure, atraumatic provisionalization, protect microcirculation, consider vitamin D3 supplementation if needed. Face everything intelligently, keep the risk low, make sure you have adequate soft tissue and bone, and if is possible, go for immediate implants. If you see moderate risk, thin tissue or limited keratinized tissue, you have to consider soft tissue first or simultaneous if you can stabilize predictably. In high-risk cases where we have large defects, high ROS baseline, we have to stage our GBR, we have to delay our loading, and we have to give more time for healing. Each phase lowers inflammatory burden, each phase protects perfusion. Use a provisional to test the plan, the phonetics, the aesthetics, hygiene access, load tolerance, shape the tissue, watch the maturation of the soft tissue. And if the provisional works, your plan was right. If not, adjust now, not after the final teeth placement. Some common planning errors. Planning to bone instead of to the prosthesis. Ignoring tissue thickness. Ignoring smile dynamics. Choosing diameter that sacrifices the buccal plate. Chasing torque. Ignoring biology. Attempting simultaneous GBR without predictable stabilization of your implants. Underestimating systemic oxidative stress. So, my message is plan the restoration first. Map constraints and redox capacity. Set numbers for bone, tissue, and depth. Choose the sequence you can deliver safely and then operate. You can download the implant planning checklist in the description below. Please like and subscribe, and thank you for watching.